Session 4. Could you hand over the session 4 details, the sheets? Session 4 sheets. It's session 3. Yeah.
Oh, yes. And I got it.
Not matching.
The WhatsApp.
Downflow is ready today. That's the way to do it.
I received the message but didn't have time to check WhatsApp.
These are the judges. This is us, all of us. These are the presenters. Okay.
Okay.
So we are also scoring, no? In addition to the judges. We are also scoring. Because these are the judges.
What topic is it? You can say paper. It's here also, no? You can say paper. See? Mistake of paper.
10, please. Thank you. So do you have a pen?
Yeah.
So good afternoon everyone. Welcome to the session 4 of Think Under the Apple Tree. So I invite Chairperson Dr. Mithun Tulsidas sir, Co-Chairperson Dr. Pooja Bang ma'am, and respected judges Dr. Naresh Babu sir, Dr. Sanjay sir, Dr. Subramaniam sir and Dr. Ragini ma'am.
Good afternoon, everyone. So after 3 sessions of Think Under the Apple Tree prelims, we are moving on to the 4th session. And I'm sure we have very interesting and innovative ideas from the bright young minds. So I hope we'll stick to that time. Now we are starting with Dr. Prithvi Chandrakanta, and the topic is Lumi intent.
Please set up the timer.
So these are the rules.
Yeah. Presentation.
So rules of the
Presentation.
वो slide display कीजिए please. हाँ.
Good afternoon, everybody. I'll be presenting over here Lumi indent. As we all know, basically in a vitreoretinal surgery, we need 3 hands, 1 sister and 1 doctor. So when we go inside for surgery, we require somebody else to actually indent for us, and that is basically our sisters who assist us. So at that time, that could be slippage, or that could be miscommunication between the sister and the doctor, and that could be a lot of accidental retinotomies. So basically, we need 3 hands and 3 instruments, and there could be a lot of complications. So we wanted a solution where we could make the depressor and endo-illuminator together. That's where we came with the Lumi indent. These are my co-authors, and the solution what we found out was using a hypodermic needle cap and putting the endo illuminator inside this, and then sticking it with the micropore. So basically, this is a very easy to do thing, because everything is actually on the table in our OT setup. So this is how we would do it. You put a transparent hypodermic needle cap and then stick with micropore, and you can see how brightly the endoilluminator illuminates the whole thing. So using this makes it very easy for us to do it with two hands. So here you can see how beautifully a trans-scleral approach of indentation with illumination is done, and this becomes very easy for the surgeon to use the other hand to use a cutter or the illumination, and you can see even the disc is illuminated very well. So this becomes very easy for the surgeon to actually recognize the second instrument and use it to cut the vitreous or even do the endo laser, and we don't really require another assistant to indent for us. So you have both your hands available to do this. So this becomes very easy. Now you can see how in a vitreous hemorrhage case, the peripheral vitreous is being cut with a cutter. So basically, this is a technique which has been done before, but then it was not. It didn't take much popularized because the illumination was very less with the other instruments. But with Lumi Indent, we have quite bright illumination for illuminating the retina periphery. As you can see, the laser also can be done very easily. And what if you don't have an endo illuminator? You can take a insulin syringe and you can put the LED light into it and then connect it to a battery source. So this can be done within 100 rupees, and it can be also attached to a power bank. And this can be used even in OPD setups. Even you can use it for indenting in scleral buccal cases. And it can be sterilized as well, except for the part of the battery. You can have quite a long wire for that. So now, as we know, the surgeon itself can indent and also do there are a lot of other instruments from different companies, but then the problem is it is only limited to that particular brand. And then there was another illuminator which is used with a cotton bud. So, but the problem is when you cut it, the scissors becomes blunt, or there is nowadays there are all earbuds which are coming in paper form, and when it becomes wet, it loses its form, and then you cannot indent it very easily, and it will also bend the illuminator. So all these problems have been removed by this Lumi Indent, and it is a do-itself, easily replicable, and it is made using discarded materials, can be sterilized, is very sturdy. It emits light diffusely and covers a large area, and without illuminator also we can do this. And as PGs and fellow in your beginning stage, it was easy for you to actually do it in the OPD and make them understand where the indentation is happening. Thank you. If you there's
check. It's on. No, in what way it is different from the one which is, because we use one commercially available. It is like a similar sleeve.
Yeah.
In fact, in that only the tip illuminates, not the shaft actually. In the model you have given, even the shaft also illuminates. Sometimes it's disturbing externally when we are seeing through the indirect. So in what way it is different from what is available commercially?
So whatever is available now is not actually available for everybody, sir. So in an institution, it is a different story because you get those instruments. But for a private practitioner where you have an Alcon machine and you have the DORC which is providing you the illuminator, so we have different machines that those people are not going to, and it is always customized towards their brand. So it will be customized to as their illuminator, only their illuminator can use it. But over here, the best part of this thing is you don't require any kind of money investing into this. You have things already on the table. You're just rearranging it in such a manner which you can use it very, very efficiently for a surgery like this. You don't have to depend on any other instrument or anything. It is just a very do-it-yourself thing.
Now, my only concern is the small smoothness of the tip, because if you see the outer cover of the, it's very ragged. So when we are indenting, and especially when the patient is under anesthesia, the force given is variable. So it can injure the conjunctiva also, which I personally feel is not, there with the commercial, because they have smoothened the surface.
But again,
so that's the only issue.
That's the only issue. But when we tried, sir, it actually didn't have that much of a problem. We used it. Actually the edges are curved around, circular. So the point of contact which comes is very less, and it actually won't poke. It doesn't poke, because the edges are round, circular in fashion. It's not square or rectangular, so it actually doesn't poke. And we've tried using this for past 6 months. We have not had any kind of problem. And then even the other one, the insulin syringe one, it has a tip which is rounded, which actually is much better than the one which we use as a 26 gauge cap.
But there the only issue is maintaining the sterility while doing the surgery.
But then only the battery part is little difficult to sterilize. But the whole, we have a longer wire. So what happens is the wire is sterilized, only that part can be used as a...
we already have so many wires, actually. We are adding one more wire to the surgery. Right. Thank you.
Thank you. Thank you, sir.
I request the presenters to please wait till the end of the session for your certificates. I'd like to call upon Dr. Yashovardhan Singh now for the next presentation.
Hello. Okay. Good morning all. I'll be presenting about an innovative and low-cost approach to non-contact corneal aesthesiometry. So more often than not, we end up seeing such patients in our OPD with neurotrophic keratitis, as well as other signs of decreased corneal sensation, even in diabetic patients. So how do we assess these patients? We have various methods. One is cotton wrist test, which has been always there since a very long time, but it is also having its own disadvantages, that it is very crude, and sometimes the results may be very variable, and you cannot quantify it. Apart from that, there is another gold standard technique, which is cockett-bonnet aesthesiometry, but then again, this is not available everywhere, and it is very costly, and also inherently the nylon fiber of a cockett-bonnet aesthesiometer tends to have some structural damage due to humidity variation. So that gave us our purpose to think about a non-contact method for checking corneal sensations. So what we thought was that if we could control the puff of air released from the NCT machine by the means of a barrier, then by regulating the pressure, we can stimulate the pressure-sensitive corneal nerve supply and thus check the corneal sensitivity. So with the same, we proceeded to make develop a simple, portable, non-invasive method of addressing corneal sensation, and to establish a reliable, qualitative method of non-contact corneal aesthesiometry for screening purpose, and to mitigate the drawbacks of traditional cockett-bonnet aesthesiometer, like humidity-associated structural change of the cockett-bonnet nylon fiber. So the design was initially done on the CAD software by taking measurements of the NCT machine nozzle, and this is how the design looked on the CAD software, and the final product, which fits very well on the NCT machine. And 3D printing was used to print the adapter. When we talk about the barriers were prepared by the nanosciences lab of Amrita Hospital, wherein the filters were prepared by a technique known as electrospinning, and 3 such filters of varying pore size were prepared, grade 1 having the largest pores and grade 3 having the smallest pore size. So now what we have is a nano-engineered filter, a filter adapter assembly, and when we fit it on the NCT machine, it becomes a non-contact corneal aesthesiometer. This is a short video depicting how the machine is set up. So we switch to the maximum setting of IOP, that is 60 in this machine. Then the center of cornea is focused, after which the adapter is applied and it fits very snugly, it does not move and there is no air leakage. And now the NCCA is ready for use. So after shooting the air puff, we ask the patient about the response. Patient is then asked if he or she could appreciate the air puff. The test begins with the use of grade 3 filter, the one with the smallest pore size, that is the highest impedance to airflow, and then gradually the pore size is increased till patient can appreciate the air puff. So we also tested the NCCA as compared to cockett-bonnet aesthesiometer and the cotton wrist test, and what we found in our pilot study was that 50 patients who were included in the study, 4 patients, that is 8 eyes, were found to have reduced corneal sensitivity by non-contact corneal aesthesiometry, who also had a lower than an normal age-related central corneal sensitivity by Cockett bonnet and esthesiometer, but had a positive blink reflex, that is a normal reflex on a cotton wisp, indicating that the cotton wisp is a very crude method of judging this, and it was correlating with the Cockett bonnet esthesiometer. So newer surgical procedures like corneal neurotization would definitely benefit from a non-contact method of assessment and tracking of post-operative outcomes, because we need to see, so like in this example, the post-operative recovery is good, but the sensation has to be checked somehow, and for that we can definitely use a non-contact method that will be advisable. And an insight into corneal sensitivity is also important in patients suffering from diabetes mellitus to look for progression of neuropathy, because sometimes these patients, the 4 patients that we have seen in our study were diabetic primarily, and in turn track retinopathy, which go hand in hand as established well in literature. This was our attempt to make a non-contact esthesiometer, which has fared well in our pilot study, and further ongoing attempts at fine-tuning are taking place. These were my references. Thank you.
How do you grade it? You said you have 3 grades established up till now, and so
Yes, ma'am. We began with making filter papers of different pore size, and then we tried and tested all the samples that we were able to create. And then subjectively, like for example, I am having a normal corneal sensitivity as per Cockett bonnet esthesiometer, because that is the gold standard. Then I compared my own corneal sensitivity with these grades, and if I could not feel the air puff at grade 1, that would mean that this is the threshold for a normal. So this is a process which we are going through. We are still developing and trying to figure out. Our next step would be to quantify the millibar pressure that is to be perceived by the cornea.
so is it still very subjective? It's the patient's...
Ma'am, even the Cockett bonnet esthesiometer, we need to ask the patient if he could feel the tip of the Cockett bonnet esthesiometer. So that is also subjective. And this is another just non-invasive method of checking corneal sensation.
And what's the surface area of the air puff?
Ma'am, the nozzle is 1 mm, which has also been done earlier. In 1998, there was a paper by Dr. Murphy, wherein he created a non-contact corneal esthesiometer. The only thing is that he created a machine. Ours is an adapter which fits well into NCT machine, so it can be used everywhere. And he also took 1 mm of the nozzle size, and the distance between the eye and the nozzle was 1 centimeter, which we have also replicated.
So all 3 grades you changed the
adapters,
the
yes, ma'am.
adapters.
I brought the adapters and filters if you want to have a look.
Right. Any other questions?
Actually, it is something very new, and like you said, but the only problem is now that you don't have any standardization.
We are working for it, ma'am.
Because the thing is that, see, I mean, to try and do this, it's very good. But you are testing on yourself, so you don't have a sample size. Like, say, for example, you have OCT in glaucoma.
Yes.
Then they have reached a particular value after a standardization of so many thousands of.
Yes, ma'am.
So this is something novel which may work in the future, but like she said, we can't judge, or we can't, there is no quantification or...
Yeah, there is no standardization,
right
that is
now,
true.
But
Yes,
it is definitely something novel and something that we can try.
That is why we are trying to fill in the lacunae here.
Yes.
That there is
Yes.
a huge lacunae that we can...
It is something new, and it
Yeah.
is something which is very good is to try new things,
Yes, ma'am.
and do something different, which is something very good, and to present it.
Yes.
So that's one.
Thank you, ma'am. Thank you so much.
Now I call upon Dr. Anukumar Singh, who will be talking on AP forceps.
Hello, good afternoon, everybody. After specialty presentations and innovations, I'm coming back to a common presentation which we all must have dealt in our life during the time of cataract training. So there are different nightmares in a cataract surgery, especially for the beginner surgeons, and also in case of expert surgeon when cases of the cataract are going out of hand, like peripheral runoff rexes where extensions are there. A Ruthenian flag in case of intumescent cataracts can also be seen. And even in a normal intumescent cataract, when surgery starts, rexes starts easily, but then again in between there are peripheral runoffs. So all these things are which are dreaded problems in a cataract surgeon's life.
So what my innovation I am doing different is that in case of normal utrata forceps, it is not very much possible because of the absence of the hinge. But in case of forceps, we can integrate it along with the scissors in the blade of the joint, where we can be used in case of peripheral runoff. We can cut the rexus margin in a different area, and the tip is blunt, as you can see, where we can use it to hold, grasp, and then continue the rexus from the other direction if possible. We can also use a different modality where the tip is sharp also, where we can use the sharp tip to tear off the rexus margin, and then after the rough edges can also be get a hold of the rexus margin, and then we can carry it forward ahead. So these are the simple modifications which are still in process of development and refining because of the complexity of the blade and the elongation of the tip, which is a little difficult to achieve in case of normal development. So we are still working on it, and the advantages in this case will be that it will save time in crucial moments, because as we can know that frequent instrumentation in and out of the anterior chamber will result into visco outflow, which will again bring the flap along with the visco. So our aim is to minimize the instrumentations, and we can keep the anterior chamber as stable as possible. And it is a complete capsular rexus solution which can be used in either of the situations I have mentioned before. So it will also get us a better hold and longer vertical tip we can provide, which will reach up to around 6 to 7 millimeters inside the anterior chamber. And even from the periphery, we can get a good hold of the rexus margin. And also it can be passed through 1.5 to 2 millimeter of incisions. And along with the rexus retrieval, it can also be used during IOL cutting and IOL explantation during the time of the faulty lens or the broken haptic. Thank you. That's all from my side.
Do you have a prototype for your instrument?
So still under development.
Okay, it's just a concept.
It's a conceptual.
Do you have a prototype? Have you used it?
Sir, I have worked on it, but I don't have a functioning prototype yet.
So you haven't done even one rexus with this forceps?
No, sir. So the problem which is coming here is that since the tip is elongated, either we cannot make it sharp to be functioning as a scissor or a blade, or if we are making that sharp, then the vertical tip which we are giving for the grasping and holding, that is not holding.
No, so it's still under
it's still under development and conceptual.
So basically, it's not yet developed. So we can't you see the practical application of it.
Yes, sir. I am agree.
Okay.
But I am in talk with the developers, and it's already being figuring out. We are figuring out the different lacunas in the development process.
Okay.
Any other questions from the judges? I'd like to call upon Dr. Atul for his talk. And if we can alternate the podia, so the next speaker, Dr. Rita, can be ready, please.
This is a chocolate or? Sir?
He's a Dr. Atul.
This is what he's made, so he's given us samples.
You can't give him marks. It's not yet ready.
Good morning, everyone. So when the world is moving to sustainability,
The doctor that you see next to me is solving one of the commonest problems
Not started,
in the
I will
OPD.
start.
Cost efficacy, I don't know. No, he hasn't done any single case.
when the world is talking about sustainability, we as ophthalmologists, what can we contribute to a sustainable future?
Just a minute, the slides are not here, AV team.
It's not.
Okay.
Hope you enjoy the show.
Hi, the doctor that you see next to me is solving one of the commonest problems in the OPD.
Hi, my name is Lakshana.
Let me first tell you what the problem is. Wastage. Slit lamps in OPD are kept on even when they are not used. And according to data, cross-infection through the slit lamp is quite common. So when Lakshana Lakshana noticed the same happening at the hospital she was working in.
I had to do something about it. How about an attachment to chin rest of the slit lamp at a very low cost, which can be used in all the OPDs and vision centers, and also it is easy to install and it should be easy to handle. Finally, a sustainable model to save electricity and also the lifespan of the bulb.
The doctor, with the help of instruments team, drew up a circuit, acquired all the parts, and dedicated her time
To fix the problem.
They came up with an infrared sensor that can be fixed on the chin rest. It lights up when the patient keeps the chin on the chin rest, and it turns off when they take the chin away. You can imagine the difference it can make.
If we can do this for one slit lamp, we can do this for the entire hospital.
So, she's in the process of avoiding wastage in her hospital. Many doctors have already started using this innovation.
I found this innovation to be very useful. Whenever we see infectious cases, we don't have to keep touching the switch on or switch off the light. And this greatly reduces the transmission of infection.
Sensor switch is really useful both in improving the compliance for the patient. I think that's one of the most important things. Only the patient keeps the chin, he realizes the light gets switched on. So many a times patients have tendency to lift it off. So that is one thing. And then the comfort level, unnecessary waste of resources is one of the plus points of this slit lamp sensor switch. I think this is a very, very useful tool.
What is the technology you have used?
IR sensor is fixed beneath the chin rest. This sensor controls the slit lamp bulb's input. When an object of interest, in our case, the chin of the patient, comes in close proximity to the sensor, it gets activated, switching on the slit lamp bulb, which in turn helps to prevent the wastage of electricity.
And why don't more people do this? That's why the team is thinking big. They want to spread this innovation all over the world. The team is now working on a DIY kit which can transform existing slit lamps to a simple clip-on addition. With an entire team, bioengineering, effective technology and a noble goal, they are reducing wastage of resources. The future is bright indeed.
Thank you.
So basically it is like seedless grapes. So you are making use of, seedless dates. You are making use of the laziness of the doctor to have this innovation.
Something like that.
So what is the principle it works on? Is it interference or is it some infrared?
It's infrared, ma'am. There is an infrared emitter and a receiver. So there are two components. The infrared rays are emitted, and when it hits an object, it will come back and received by the receiver. So when there is an obstruction to it, the sensor will sense it, and the slit lamp will turn on. When the obstruction goes away, it will turn off. So when the patient comes in close proximity to the chin rest alone, the slit lamp will turn on its own. We don't have to switch it on or off. So it's like an automated version. So in this, in a way, we are motivating the patient also to keep their chin rest in the correct position. Some patients might be uncooperative. So we can tell the patient, unless you keep your chin properly, we cannot examine you. So we are giving the patient also a part in their own examination. And also the aspect of cross-infection and sustainability of the bulb lifespan. When sometimes we forget to switch it on, come back after lunch, and if we find it red hot, the slit lamp module. So this can prevent that.
Any electric shock given to the patient if the chin rest is not properly placed?
No, sir.
Two things I want to know. What's the cost? And secondly, how does it prevent cross-infection?
So in some cases, like to answer your first question, sir, the raw materials as of now, the raw materials comes to around 200 to 250 rupees to source, and we are developing a fixed plug-on module in which there will be just a plug-on thing which we can plug it on to the slit lamp. So we are bringing the cost to less than 500 rupees.
Okay.
And the cross-infection is, we see a patient of conjunctivitis and we hold the patient's lid, and then we might accidentally go and switch off the switch with the same hand. So in this, we don't have to switch off the lamp at all. So there is a chance that that slit lamp, the doctor's part, we don't get it infected. So just a small part in the small application.
Okay.
interesting part. And we have to clean with the alcohol swab. Does
Yes,
it
sir.
get affected with that?
No, sir. The infrared sensor we have cleaned and we have tested with alcohol swab, and nothing has. It stays intact. The functionality remains the same.
Have you foreseen problems with children because their heads are small and sometimes they have to be closer to the headrest than the chin rest? And
For now, we have tested it in the standard slit lamp available in our general units. In the pediatric hospital separately, we have not tested. But since these slit lamps are the same in both the places, it should work. We can modify it if needed.
So, but still, if you have to change the illumination or the filter, still you have to use the hands, right?
Yes, definitely. It is just for the on and off. Just like, so the eventual plan in the future is to give this technology to the slit lamp makers so that they can integrate it into their systems, and any slit lamp we buy, it will have this integrated system. So we have just introduced a technology now. We are in talks with slit lamp companies in which they can acquire it and put it in their slit lamp and they give it to us itself.
Yeah, that would be better because preventing the cross infection, sometimes we might have to change the filter.
Yes, definitely. So I feel in the future this can be done in all slit lamps. Thank you. The samples that were provided are for the next session actually.
Okay. Yeah. Now I call upon Dr. M. Rita, who will be talking on outcome of corneal tattooing in patients with total corneal opacity in a tertiary care center.
Good morning to all. My topic is outcomes of corneal tattooing in patients with total corneal opacity. The aim of the study is to determine the safety, efficacy and complications associated with corneal tattooing and to explore the patient's satisfaction and improvement in self-esteem. It's a prospective cohort study conducted in a government tertiary hospital in Tamil Nadu. This is followed for 5 years. And the technique used is, it is a lamellar keratectomy with the surface impregnation with filling of the dye within the chamber. And this is a small video showing this corneal opacity with no perception of light, only for the cosmetic purpose. To the side port, the corneal spatula, it is inserted and the pocket is created in the corneal stroma. So in this case, so Sinake is there, adherence is there. So we can't go from the single side. So another pocket is created in the opposite side with a crescent blade. And again the corneal spatula is introduced. And the uniform pocket, stromal pocket is created. And we are filling the dye within the stroma. And the wounds are closed with the 10-0 nylon. And the chamber is tight. So in this patient, so cornea band-shaped keratopathy is there. So we prepare EDTA and keep it for 3 minutes. And it is removed, scrape it off with the cotton bud. Still in this case, it is not going. So we, with the crescent knife, it is scrape it off. So again, the dye is applied over the raw area. The bandage contact lens is kept. So this is a post-operative outcome of the patient. So methodology we used is pre-operative evaluations and patients with complete total corneal opacity with no visual acuity were selected, and the baseline score of Rosenberg self-esteem scale in the native language we filled up. Then the procedure we did. Then the post-operative assessment. This is also we have to fill the self-esteem score at 1 month, 3 month and 6 months interval. So patients are followed weekly for 1 month and monthly for 6 months and assessed for complications like infection, corneal erosion and fading of dye, etc. The satisfactory score by Rosenberg self-esteem scale for assessing the improvement in self-esteem of the patient is assessed in every week. So the Rosenberg self-esteem scale is the most popular scale. It consists of 10 statements about feeling of self-worth and self-acceptance, to which the respondents indicate their level of agreement on a 4-point scale. Normal score range from 0 to 30. So this is the scale. We have converted it into the local language. And the score between 15 to 25 is normal. Scores below 15 suggest low esteem. And this is a graphical representation. So before the procedure and after the procedure, that shows a gradual increase in the self-esteem. So this is a pictorial diagram. And the efficacy, it is very simple and cost-effective procedure with minimal complication, no fading of colors, cosmetically good outcome with good satisfactory effect. So adverse effect, almost all the patients have pain and redness in the first week of post-operative period. It was treated with antibiotic and steroids and lubricating eye drops. And summary, no participants were found complications during the study period. Overall, the impact of corneal opacities on self-esteem is multifaceted, encompassing both cosmetic and functional aspects, addressing the psychological effects of corneal opacities in addition to their physical effects, which is important in promoting the well-being and quality of individual's life. So there are few limitations. There is only 3 patients, score was less than 15. Maybe it is because of the color difference between the 2 eyes. So we plan to rectify this by using different shades of dye in the upcoming patients. These were my references. Thank you. These are some of the patients.
How did you prepare the dye? Is it commercially available?
Yes, sir.
Your charcoal mixed with something?
Yeah, it's commercially available, sir. Namin sir, you can get it, sir.
Okay.
And what's the maximum duration of follow?
5 years follow-up is there. Still it is there, sir.
Still it is there, 5 years.
Still it is there, no fading, nothing, no
Technique that you mentioned in the slides spoke about surface impregnation along with pocket wash with the dye. Whereas the video that you showed a pocket wash of the dye, but you just flooded the dye on the surface.
Yes.
The dye which is flooded on the surface will never stay. If you have opacities on the surface, you need to actually do the puncture technique either manually or mechanically for the dye to stay. If you're just inserting the dye in the pocket and you're just doing a superficial keratectomy and flooding some dye on top and putting the bandage contact lens, the superficial dye will fade off in just 1 or 2 days' time. The verbal part said
Actually,
it correctly.
This one patient only I did. My other cases only total corneal opacity. That's cosmetically still it is there. No fading, nothing.
No, the point that I'm trying to make is if you have surface opacities, you need to de-epithelize and do the impregnation technique. Just painting the dye and putting the bandage contact lens will not make the dye stay. I think you mentioned it in that way in your slides, but what you showed was slightly different.
What's your sample size, ma'am?
20, ma'am.
20.
Did you see any allergic reaction or any kind of hypersensitive reaction? Hypersensitive reaction to the dye? Allergic reaction.
All the patients are comfortable.
I think we'll call the next speaker. Thank you very much.
Thank you.
Dr. Narendra Singh Verma.
Dr. Vivekanandam can please be ready on the next slide.
Respected seniors, expert on the dais, and my dear friends, very good morning to all of you. And I want to present my topographer we are developing since Corona time. So this is made in India topographer. Like other topographer, it will provide you keratometry in 3, 5 and 7 millimeter zone, axial heat map, angle alpha and white to white. It is also having additional feature like image guided system for easy and error-free marking of axis of alignment. So in this system, there is no need of pre-operative marking like image guided system. You have to do only intraoperative marking at the time of surgery, just before putting the toric lens. So let's see how it works. This is the patient I operate on the 1st of March. Basically, it is a anterior surface topographer. In place of Placido disc, 600 color LEDs are used. It measures central 9 to 10 millimeter part of the cornea. These are the results. This is raw image. The white to white is 11.66 millimeter and angle alpha is 0.45 millimeter. This is anterior surface keratometry in 3, 5 and 7 millimeter zone. In 3 millimeter zone, there is 1.1 diopter cylinder in 172 degree. The steep axis is not showing any skewing, so it is regular astigmatism and it is confirmed by axial heat map. This is manual image guided module. The system automatically marked the anterior steep axis at 172 degree. In this topography picture, identify some prominent limbal structure, mark them as landmark points. On the right side, there is pigmented part. I mark it. It is at 179 degree. On the left side, this is some whitish pigment structure. I will mark it. It is at 23 degree. These two are my reference point. So preoperative 0 180 degree reference marking is not required. It eliminates error due to head tilt and cyclotorsion. If patient moves his head during topography, the steep axis will rotate. Landmark points will also rotate. The distance between the landmark points and steep axis will remain the same. It will not change if the patient moves his head during examination or when there is cyclotorsion when the patient lie down. I will enter my data in Barrett toric calculator and get the axis of alignment. It is 176 degree. So I will change axis of alignment from 170 to 176 degree. I will save this picture in tablet or laptop or mobile. This picture is displayed in operation theater on laptop. The surgeon can identify easily the pigmented structure which is at 179 degree on nasal side. On temporal side, this white patch is at 23 degree. These landmark points are marked which are at 179 and 23 degree. 179 and 23 degrees also marked on the degree gauge. These marks are coincide with the marking on the cornea and axis of alignment at 176 degree is marked. Post of day 3, the axis of toric lens on the slit lamp is at 170 degree. It is confirmed by the retroillumination picture. Axis of alignment was 176 degree. The present position of toric lens is 170 degree. There is misalignment of 6 degrees. Thank you.
Other advantages of your topographer other than made in India?
And it will be very economical.
What's the cost? That's what I want.
Yeah. So presently it is costing 20,000 for us 20,000 rupees. Yeah, for one model.
Any other advantage compared to?
And it is very easy that it will save the time. Lot of all the things which are practical things are involved here. So within nothing, because economy is the only thing.
Okay.
So can we use it for diagnostic purposes like corneal?
It is anterior surface topographer and it is just like Cassini. So that and for anterior surface we are working on the P2 also. Purkinje second image. We are dealing with the infrared camera. So if we'll able to get the P2, then we got the P2 in some cases in which the cornea is very crystal clear. So we can get the TK also. So that will be there. So in some cases you will get the TK. You can compare it with the what is the net astigmatism by the Barrett. If the both are same, then you can rely on that.
So right now it's not evaluating the posterior surface.
No, not evaluating, sir. Because P2, getting P2, the cornea should be very clear. So in some old patient, that's not possible.
Do you have comparative studies with the available ones?
So I'm using
standardized ones?
No. I am compared with the Cirrus for the keratometry and Cirrus topographer. So
what is your sample size?
Yeah, I have checked in the my corneal surgeon. They are coming to my hospital. He is having Cirrus, his eye, my eyes. So it is nearly same. What is the problem with the topographer? That when you capture the picture, you can capture from slightly backward and slightly forward. So if you are taking picture from slightly backward part, 0.534 millimeter backward part, the image size will be smaller, so it will give higher reading, but the cylindrical power will be the same. So for cylindrical power they are very good. For the actual that will not change. So that is the problem with the topographer. That is not there with the IOL master because they are having telecentric lens. So the image size will not depend if you are taking picture from slightly forward or backward movement, but the telecentric lens is very costly. Thank you, sir.
And now I call upon Dr. Vivekanandan, who will be talking on flange techniques made simple. Dr. Vivekanandan? It's not. Call upon Dr. Aishwarya Joshi, who will be talking on DYI suprachoroidal needle.
Dr. Prithvi can please come on this side. Is Dr. Prithvi there?
Good afternoon, I'm Dr. Aishwarya, and today I'll be talking about a model I'll start it. A model of suprachoroidal needle which we have designed. It is a DIY technique and it is very easily available. The materials are very easily available and it can be used by anyone. And now with the advent of suprachoroidal injection drugs in the form of tyrosine kinase inhibitors, triamcinolone acetonide, and even gene therapy, this will be of utmost importance to learn this technique.
Done in 10 patients to analyze the technique and safety of suprachoroidal injection by our own DIY model of suprachoroidal needle. The materials required are 26 gauge needle, 22 gauge vein flan IV cannula, 15 number blade with a Bart Parker handle. As shown here, the length of a 26 gauge needle is 11.5 millimeters. Keeping this in mind, 22 gauge Venflon IV cannula is measured for 9 millimeter length and is cut. Care should be taken for the ends to not rebound off the sterile area. Then we assemble the 9 millimeter long cut part of the cannula over a 26 gauge needle in such a manner that it leaves 1800 micrometers of the needle end exposed. Technique, 2 suprachoroidal injection needles can be made from just one cannula. In this patient, we planned intravitreal injection of anti-VEGF with suprachoroidal triamcinolone acetate injection in the same sitting. At 3.5 millimeters from the limbus at pars plana zone, intravitreal anti-VEGF was delivered as usual. An AC tap was done for decreasing the eye pressure and allowing the injection in suprachoroidal space as much as 200 microliters as shown here. Entry should be made at 45 degrees for 1800 micrometers of the exposed needle to pierce the sclera and sit in the suprachoroidal space snugly. After gently removing the needle, there was no regurgitation of the drug. This ASOCT captures the suprachoroidal space in its usual state, wherein this picture was taken post-suprachoroidal injection, which confirms the presence of the drug in the right space. With our design of suprachoroidal injection, we titrate the length of the needle in such a way that there is no inadvertent entry into the vitreous cavity. This was proved in all of our 10 cases. The most common complication noted was a subconjunctival hemorrhage in 3 patients. With newer upcoming treatment modalities requiring suprachoroidal drug delivery, such as gene and cell replacement therapy, we contend our model to be minimally invasive, cost-effective, accessible, and an overall efficient in-office procedure. This being the solution to the expense and patent issues associated with currently available alternatives for suprachoroidal mode of drug delivery.
No, the commercially available needle from clear side is 900 micron and 1100 micron
sir.
for the thickest sclera.
Yes, sir.
The basic difference is if you see the opening at the tip of the needle is quite, it's longer in case of these needles.
Yes, sir.
Compared to what is available in the clear side needles. So that gives a precise delivery, number one.
Yes.
And number two, there were two RCTs. One is sapphire, the other one is topaz.
Okay.
Both have been abandoned, saying that there is no difference between intravitreal, the anti-VEGF versus a suprachoroidal injection of steroid. So they halfway through, after seeing the result, they abandoned. So are you still giving this suprachoroidal, the steroids for vein occlusions and the diabetics? Because there are no evidence for that. It has been abandoned already.
Yes, sir. So from our pilot study, we've seen that the incidence of steroid-induced glaucoma is lesser. Plus the fact that we are not giving it inside the eyeball, it induces, the chance of inducing a cataract is way less. And in eyes which are vitrectomized, eyes which don't have a lens, aphakic eyes, in them you can easily give this. There will be no migration of the drug into the anterior chamber as well. And it forms a nice depot which is easily, the bioavailability is much better considering that it is in that compartment. So that is why it is better, and there have been studies on this. There is HULK trial for diabetic macular edema, then there is Peachtree trial for non-infective uveitis. So for all these, for RVOs also there is Tanzanite trial. So they have given, but they have used the conventional needle which is a little expensive, it's 650 rupees. And here you can make 2 needles in less than 100 rupees.
But a similar model already available, right?
Yes, sir. Others have used it, but our technique is such that we keep the end which goes inside a little longer so that we can give a valved entry and there is lesser regurgitation and the needle sits snugly inside the suprachoroidal space. So the drug nicely goes in, as in the bevel is facing the choroid. So we are not, the chances of puncturing the choroid is way less. Thank you.
I call upon Dr. Prithvi Chandraganda, who will be talking on Retilite.
Good afternoon, everybody. We're talking on the Retilite. So as we know, as a vitreoretinal surgeon, for us during surgery, the one most important thing that we need is an endo illuminator. So without a light source, it is very difficult for us to do a surgery. But what if the endo illuminator goes off and we don't have an illumination? That becomes a big problem, and then we'll have to even postpone the case or wait for somebody to change it. So this was the problem statement, and that's why we wanted a frugal novel illuminator device for emergency purpose. So that's why we came up with Retilite. So basic principle is using a xenon light. It focuses light on the endo illuminator head. So even without a lens system, we can do that. So we designed 2 adapters, Reti adapter and light adapter. So these 2 adapters such that we can use the LED for illumination in one adapter and the other one for the head of the illumination. And it is such design that you can actually change the adapter and do a permutation combination to accommodate any of the other companies or any of the other devices like LEDs or torch light or anything, and just fix it and make it, you can use it as an endo illuminator source. So this costed around 1,500 rupees, and this is the 3D printed model that we have. So you can see how these 2 adapters can be removed easily, and then in one head you can put any of the endo illuminator from any company. You can design it accordingly. It is very simple to design one, and then the other side is has the LED light bulb, which can be even used with a small cell button also. But the illumination of this is a little lesser than the one which we have in our machines. So we thought, why not increase the illumination into a little more so that we can get better illumination. So that's where we came with the Retilite 2.0. Here we used a better illumination LED, but then we required a heat sink and also a fan to reduce the heat, because as the light increases, intensity increases, we need a source, we need to cool it down too. And this can be used with the power bank which we have. So it's a 3.5 volt power bank which gives very good illumination. And as you can see, it can give you diffuse light, it can give you even a spotlight for orbit surgeries, And also this adapters can be changed accordingly if you want to use it for any of the endo illuminators. So you can see how beautifully you can appreciate the light coming through the endo illuminator. So this is a sample where we use this endo illuminator, and you can see how beautifully you can actually illuminate the retina, and you can go up with the surgeries. And even in anti-segment surgeries where you need retro illumination but you don't have the whole machine as a retina surgery machine, you can always use something like this, which becomes very handy for anti-segment. And also in orbit occuloplasty you have, we can use this for as a spotlight. Also we can use this for corneal DMDs also. So this is an ultra portable device which comes for 1,500 to 5,000 rupees. So as you can see, I use this, I keep this in the pocket itself. So you can just use it, very easy to portable also. Thank you. I have a device if you want to see.
Looks like a submarine. Don't. Okay. Yeah. You will answer some questions? Yeah. No, basically a lot of things are there like this, the external source.
Yes, sir.
So my only concern is what about the light toxicity to the retina caused by this, because we have got a lot of filters, and we have got what you call the virtual filters also in most of our machine, either it's red-free or all those things, thereby reducing the toxicity. So this you have done any validation by doing maybe in any of your macular cases, maybe a macular hole or ERM, by doing ERG prior and post surgery. So what about the toxicity in the presence of especially ICG or any other dye?
Yes, sir. So basically, we went back and saw the other portable devices which are there, which cost around 1 to 2 lakhs, and we opened up and saw the LED. So we exactly got the same LED that they are using, which has already been used in our standalone endo machines. So those which have been used is almost 12 watt, and which we have used here is just 6 watt. It is actually comparatively very less compared to this thing.
In between the light and your adapter, is there any filter in other machines? Because it is there in all the high-end machines.
Yes, sir.
Because when you see even in a Alcon machine, no financial institute, interest, you keep the light on your gloved hand. It will create a sort of a heat burn. Actually.
Actually which they use in Alcon is a xenon light. So that might require filter and such, but what we have we studied through other machines which use LED lights, it doesn't really require. And this LED is the same one which we use in the slit lamp also. The recent slit lamps which we are coming with
that
LED.
That is external actually, and you will not be focusing for 30-40 minutes inside the eye.
It's the inside the LED inside the illumination source is the same LED.
No. What I am saying is in slit lamp you will not be burning the retina directly.
Exactly.
It is just
this is exactly the one which they use in the other box.
Thank you very much. So with this, we have come to the end of this session, and I request distinguished judges to kindly collect the certificate. May I call upon Ragini Madam, Dr. Ragini Parikh, please.
Oh, there's someone taking photo.
No,
Hi, ma'am. Thank you. Thank you. Thank you, ma'am. Thank you. Sanjay.
Just a minute, ma'am.
Even the participants, you need to collect your certificates.
Thank you.
Rajiv Gupta. Dr. Mithun, your certificate.
Dr. Prithvi, are you here? Yeah, please collect your certificate. Dr. Yashovardhan Singh.
No, yes, but one more, the last one.
This one more? Oh, he presented today, sir.
I think it might be only one.
No, there are two. I call upon Dr. Anup Kumar Singh.
Wait, there's already one.
Yeah. Dr. Yashwardhan Singh.
There's no
मैम आप मैं नाम बोलती हूँ आप दो
But photo?
कब somebody will take photo. Dr. Anup Kumar Singh. Come. मैम आप आइए ना. Dr. Atul.
Yeah.
Dr. Rita, ma'am.
What he's saying, we should stand in front.
Okay, we stand in front.
So that the